Welcome back. This is part two of the Nurses in the Know pre-workshop module for CDC nurses who are going to the VA. And in this part two, we're going to focus on treatment algorithms and the drugs used to treat asthma and COPD. Now, in part one, our very brief first module, we looked very briefly at the pathophysiology and the similarities between asthma and COPD. And in both asthma and COPD, remember, inflammation plays a very important part. So in asthma, we have inflammation that results in swelling and constriction of the muscle, the smooth muscle there in the airways, and that can cause obstruction. In chronic obstructive pulmonary disease, COPD, we can have damage that's produced either at the lung tissue itself with a loss of elastic tissue in the alveoli, and that results in emphysema, or we can have a chronic inflammation of the airways with chronic mucus, and that can lead to chronic bronchitis. But in both cases, inflammation is going to be the key underlying bad actor, so to speak. Okay, so just as the pathophysiology of both disorders is going to be similar, we are seeing that the drug therapy of both disorders is going to be very similar. There's going to be a good bit of overlap. And most recently, there has been a good bit of literature on the idea that many patients exhibit features both of COPD and of asthma at the same time. And so perhaps there are really either two manifestations along a spectrum of disease, or perhaps they can occur at the same time. But many of the drugs and the drugs that I'm going to focus on here can be used in both conditions. Now, overall, very quickly, the goals of management for chronic asthma, and this would be chronic asthma and COPD, these are going to be your chronic diseases, will be to reduce impairment and reduce risk. So in impairment, we want to reverse obstruction, we want to reverse hypoxia, we want to prevent further chronic symptoms, we want to reduce the use of rescue medications, we want to maintain or restore as near normal pulmonary function, exercise tolerance, and activity as we can. And very, very importantly, you want to meet, to the best of your ability, meet patient and family expectations of and satisfaction with care. This is important because these are chronic diseases, and so your patient will be taking medication to control these diseases for the rest of their life. Having better satisfied patients means you have more compliant patients, which means that you'll have a better outcome. In terms of reducing risk, you always want to reduce the risk of further exacerbations, which can be dangerous. You want to prevent complications from these diseases, further loss of lung function, further damage to lung tissue. In children who commonly have asthma, you want to avoid reduced lung growth. And of course, you always want to reduce mortality and morbidity. Okay. Now this represents a stepwise approach for managing asthma, and this would be in adult patients. And I like this particular diagram, this particular image, because it really gives you an idea of the stepwise process here. So along the top here, you see a description of your patient's symptoms, whether they're intermittent asthma or whether they have persistent asthma that would require a daily medication. And then based on your description of your patient's symptoms, you place them on the step. And the steps here also will indicate the preferred drugs at each step. So for example, if your patient required daily medication, we would say that they had persistent asthma. The preferred drug of choice here is going to be a low-dose inhaled corticosteroid. Alternatively, you could use these other drugs, which would include cromolyn, a leukotriene receptor antagonist, nitochromil, or theophylline. Okay. If your patient still did not have good control, then you would step up to the next level, which would be an inhaled corticosteroid and a long-acting beta agonist, or a higher dose, a slightly higher dose, inhaled corticosteroid. If, however, your patient had maintained adequate control for several months, you could try to step down. And the step down here for step one would be a short-acting beta agonist as needed, as like a rescue inhaler. Okay. So these are the recommendations that actually come from the National Heart, Lung, and Blood Institute from the Expert Panel 3 report. And we went to that site in the previous presentation. All right. Now this, in contrast, represents the staging of symptoms according to the gold standard. And the gold, remember, was a global initiative for chronic obstructive lung disease. And in the gold guidelines, you can stage your patient on the basis of their symptoms as mild, moderate, severe, or very severe, or stage 1 through stage 4. And these are going to be descriptions of their symptoms here. Now, the gold guidelines were just updated in 2015, and so they've added another layer to that. I'll show you that in the next slide. But also notice here, you're going to be using inhaled therapies as well, short-acting bronchodilators like short-acting beta agonists. You're going to use long-acting muscarinic antagonists as well. You're going to use long-acting beta agonists. You're going to be using corticosteroids as well. So we have quite a bit of overlap of the therapies that we're going to be using. Okay. And then additionally, this is what we just referred to. These are the updated gold guidelines. And this actually recommends, what this is a picture of the gold stages of the disease. So we go based on symptoms. So we've got 1, 2, 3, 4 here. So these would be the least severe to the most severe here. But then additionally, you're going to describe your patient in terms of the likelihood of their exacerbation. They're having an exacerbation, whether they would be less likely or whether they would be very likely to have an exacerbation. And then, so we organize them a little bit differently as A, B, C, or D. So this scheme actually sort of takes into account both the severity of their current symptoms and the likelihood of exacerbations. And the drugs that are going to be used here would include inhaled corticosteroids, long-acting beta agonists, long-acting muscarinic antagonists, and then also possibly short-acting beta agonists and short-acting muscarinic antagonists as well. And we'll talk about those particular drug therapies right now. Okay. So in terms of beta-2 agonists, and I've just given a few here, we've got albuterol, which could really be considered the prototype drug for our purposes here. And I'm also showing levoalbuterol. This is actually going to be a particular isomer of albuterol. And then we've got formoterol. Formoterol is still available. This is going to be a long-acting beta agonist, whereas albuterol and levoalbuterol would be short-acting beta agonists. And then also notice here I'm showing a combination product, just one in this case. This is salmeterol, which is a beta agonist, which is going to be found in combination with fluticasone. This is going to be an inhaled corticosteroid. And this particular combination product is called Advair. And so I'm sure you're very familiar with this. So we describe the beta agonists as being either long or short acting. And you can find them, you almost always will find the long acting agonists in combination with an inhaled corticosteroid because they're safer to use that way. Okay. Beta 2 agonists are going to be the most effective bronchodilators that we have. Albuterol is available for inhalation and also available for systemic administration. The mechanism of action I'm showing over here, these are going to stimulate beta-2 receptors, and because they are administered by inhalation, they stimulate the beta-2 receptors that are found in the muscle, in the smooth muscle of the airway, and this in turn initiates a cascade of cellular events that leads to bronchodilation, relaxation of the smooth muscle there. Beta-2 agonists, these are going to be relatively selective for those beta receptors that are found in the airways. And you'll have little activation of the beta-1 receptors that are found on heart tissue, heart muscle. So this means that with an inhaled agonist in particular, you're not very likely to have cardiac adverse effects. Adverse effects, is very serious adverse effects here, are going to include urticaria, arrhythmias, and paradoxical bronchospasm. Those are more likely to occur in patients who are taking the long-acting beta agonist here with without that are not formulated with a steroid here. And there does seem to be, for some as yet unknown reason, a greater likelihood of patients having a severe, life-threatening asthma attack that could result in death. More commonly, adverse effects could result in nervousness, tremor, palpitations, or tachycardia, bad taste, or throat irritation, because many of these are going to be administered orally. I'm sorry, are going to be administered by inhalation. Okay. Methylxanthines are going to be the next class of drugs that I'm going to touch on very briefly. These used to be the drug of choice, and they've fallen out of favor because honestly they're not very safe. Muscle relaxation is believed to be the mechanism of action, and we think that the mechanism is going to be related to what we saw with our beta 2 agonists. Unfortunately, particularly with theophylline, the half-life is variable. It's metabolized in the liver, which means that there's a lot of opportunity for drug interactions, and metabolism also happens to occur by those CYP450 enzymes. Additionally, there are large interpatient variability in theophylline clearance, so serum levels can vary widely in between patients. So this means that theophylline is sort of tricky to use. Adverse effects can include things like cardiac arrhythmias, tachyarrhythmias, seizures, and even death, even in patients that have received a dose that they normally had a good response to. So these are typically not used as first-line drugs anymore. You may see a patient who still does use them for some reason, but inhaled corticosteroids and beta agonists are much more safe. All right. Anticholinergics, I'm just giving you two here. Ipratropium bromide, which is Atrovent, and tiotropium bromide, which is Spiriva. Both of these would be used primarily for COPD, but we are seeing now that some patients who have asthma that have not responded well to their other medications are using the anticholinergics and are getting some kind of relief. Ipratropium would be considered a short-acting muscarinic antagonist, and the tiotropium would be a long-acting muscarinic antagonist. Um, these agents also, they're administered by inhalation. They have very poor absorption, which means that the likelihood of adverse effects is going to be very small. And they are blocking the effect of acetylcholine, particularly of vagal stimulation, to produce muscle contraction and to increase secretion, particularly of mucus in the airways. So a recent study indicated that tiotropium was at least as effective as a long-acting beta agonist and a steroid in controlling asthma symptoms. And so this is making this an option that would be more likely to be seen in patients who have asthma as opposed to COPD. And then lastly, inhaled corticosteroids. There are a number of these, and I'm just giving a very few of these. And again, here, notice I've got the fluticasone and the salmeterol. This is our long-acting beta agonist with our inhaled corticosteroid. Generally, these are going to be working to decrease inflammation as steroids do. Inhaled corticosteroids are very safe to use in asthma, and in fact, they are one of the first line drugs to do this. They have a number of ways that they inhibit the either the activation of inflammatory cells or the production of inflammatory substances, and thereby reduce inflammation and swelling in the airways. Adverse effects are going to be very rare when these agents are used by inhalation, and they would include things like adrenal suppression or osteoporosis or growth suppression in children, bronchospasm, and again, that would be kind of an idiopathic bronchospasm, and also peptic ulcers. More commonly, what you would see would be sinusitis, headache, nausea, diarrhea, and also oral candidiasis. So one of the things that you need to instruct your patient about when they use these medications is to rinse their mouth out or brush their teeth after they use that, and also to keep their inhaler clean. So this brings me to the end of the very quick overview of the drugs that are used to treat asthma and COPD. Thanks very much.